Thank you, Kimberly.
What was the code to put in the chat?
I can put it in now. It is 18862. All right, and Dr. Sata, if you want to go ahead and share your slides, we can just make sure that everything is showing well.
Does that
There
look
we
okay for
are.
you?
Looks fantastic. Thank you. And I'm going to go ahead and get started 1 minute earlier than I had promised, mostly to also to welcome everyone to Department of Medicine Grand Rounds. Also, two quick announcements. One is thank you for being here and happy Thanksgiving week to all. Two is that for Department of Medicine Grand Rounds next week, it's canceled as we will be having the Department of Medicine Leadership Retreat. So Grand Rounds will resume on December 10th with one of our resident-led CPCs. So definitely do not miss that. We are so excited to have you all join us today so that we can welcome our lecturer, Dr. Suchita Sata. She is an associate professor of medicine at Duke University School of Medicine. She graduated from the University of Wisconsin-Madison, earned her medical degree at Columbia University, and then went on to complete her residency in internal medicine at the Hospital of the University of Pennsylvania in the healthcare leadership and quality track. Dr. Sata is an academic hospitalist and clinician educator, and she's been designated a fellow of the American College of Physicians and senior fellow of the Society of Hospital Medicine. She leads educational efforts at Duke in teaching trainees about high value care and reducing waste in healthcare. And her publications in the field include collaborating on the updated Choosing Wisely recommendations from SHM that I know we all read, as well as articles on the appropriate use of IV albumin, PPIs, SGLT2 inhibitors, all the good stuff, GLP-1 RAs, in addition to stewardship of C. diff testing strategies. She's also a deputy editor for the Journal of Hospital Medicine's Innovations Corner, which is an article series she created for the dissemination of QI efforts to a national audience. She and her partner have two daughters, currently 2 years old and 3 months old, and she used to have free time. And with that lengthy list of accomplishments, in addition to her personal life accomplishments, that doesn't surprise us at all. But we are fortunate to have her join us today, and she will be lecturing to us on From Waste to Value, Evidence-Based Strategies for Institution-Led Change. Thank you, Dr. Sacha, for being here with us.
Thank you so much, Dr. Law, for that really kind introduction. And thank you to Dr. Del Rio and the whole team for the invitation to join you. Um, if I forget at the end, I wish everyone a happy and safe Thanksgiving holiday. And hopefully everyone can wrap up their work early and enjoy some time away. I was asked to share a little bit about myself to start. And it's always hard to talk about yourself, but I wanted to share this in particular for the trainees in the audience because I remember thinking that all the stars that I see doing things like this, I never thought I'd give a department grand round, so thank you for that. But it always feels like the people who are doing this have a linear journey that is a shining bright light off in the distance and achieving. And I thought that was going to be my plan as well until a couple years ago when I had my first kid and the things get busy. You have to pause, pivot, reflect, prioritize. And then our daughter was a little bit medically complicated, and there were plenty of things to make me feel like I was working four full-time jobs at once, which is, two full-time jobs is what academia is. But the four full-time jobs was a lot. So I really thought about what brought me joy and what really mattered to me, what was consuming time I didn't have, and then what could I continue to grow from and learn? And I wanted to particularly shout out mentors who helped me over the speed bumps. And you'll recognize amongst the crew of phenomenal clinician educators, clinicians, QI leaders, hospital health system leaders, Dr. Dan Hunt here from your fantastic institution. So I wanted to make a big shout out to my mentors who help over the speed bumps, and then also allowing myself the permission and my mentors giving me the permission to redefine a professional and personal identity, to think about being open and pivoting and prioritizing, and that academia and a career in academic hospital medicine is not a linear journey. Every career comes with S curves. And shouting out the visual abstracts in the Journal of Hospital Medicine about thinking about less about what I wanted to do and who I wanted to be, which is what I'm embracing now as I think about life. It's my first week back from maternity leave, so I now have a 3-month-old, in addition to a 2-year-old, and I have no sleep and plenty of caffeine. So hopefully to the trainees out there, it is possible to do it all, just not all at once. So moving forward, the learning objectives for the conversation today, wanted to chat with you about identifying basic principles of high value care, recognizing the impacts of cost of care on patients, understanding opportunities to intervene in the culture of changing practice, and then applying evidence to plan institutional efforts to reduce overutilization. I wanted to focus a lot on kind of what are some examples we've seen out there, what has worked, what is prompting high value care, and what kind of lessons can we take back to each of our institutions, in particular, thinking about how an institution as wide and varying as Emory's Department of Medicine, as well as Emory's health system affiliates. So let's start first with something that happened very recently. This is a picture of a bridge that collapsed during Hurricane Helene in October, which impacted Western North Carolina significantly. And I know there were definitely lots of flooding in the Atlanta area. One thing that happened was a bridge to the Baxter International plant, which produced about 60% of the IV fluids used in our healthcare. So with the IV fluid crisis, what our hospital and health system had to do was think about centralizing supply, changing our EHR order sets, educating clinicians about alternatives, re-examining our standard procedures, canceling certain procedures, including operations, which is definitely a struggle. But, an arthroplasty uses liters and liters and liters of fluid. So does hysteroscopy. Thinking about what needs to be triaged on a central level, having those disciplinary conversations on with consensus as well on what are safe alternatives. So we learned quite a few lessons very quickly, but it also forced us in a crisis to conserve creatively. Some methods we had to deploy, including redistribution, resourcing alternatives, relying on the federal government to think about where else can we get rapid approval for alternative solutions, rationing, unfortunately. But the most important thing was that we had to do it safely, in addition to the provider level, institutional level, and multi-system work that had to be done. I want to talk about another case that still, it makes me feel ill every time I see this picture of the spike proteins. But I know that we all many of us remember the COVID-19 pandemic from just a few years ago. And during that early time, we had to think about consensus on alternatives as well, reusing single-use PPE, rethinking hospitalization and building rapidly programs of hospital at home, expanding telehealth and convincing places to pay for it, pooled testing of swabbing entire freshman classes all at once and putting that into a pooled test. And if small groups were positive, then doing individual tests, we didn't have enough for them. And then partnering, of course, across the continuum of care, of the ED to hospital to post-acute care to home, and also doing that research during that time as well, right? We have an explosion of early trials on making our care evidence-based and also making sure that what we were doing was safe and patient-centered. So I use those two examples to say that if we can practice high-value care during a crisis, right? We were forced to practice during scarcity. We were forced to practice and conserve resources when there were shortage of resources. What can our institutions do to help us during periods of plenty? People have said that never let a good crisis go to waste. But let's think about really like when the sun is shining, how do we repair the roof of healthcare? So I wanted to frame it for the conversation today of understanding waste in healthcare first, a framework for high value care and strategies to reduce low value care, and then really thinking about institution-led change as well as keys to implementation. I would love to answer questions as I go along, but I cannot adequately monitor a chat as well. So I will save some time for some discussion because I'd love to learn from your teams as well what has worked.
We can keep an eye on the chat and let you know.
Oh, thank you so much. And please do feel free to interrupt at any time. So let's talk about what is waste in healthcare. Simply, it is activities that don't improve patient outcomes. We don't want to do anything that hurts patients, but we don't want to do things that don't actually help patients. And it may increase costs. I want to de-emphasize the price tags throughout this conversation because I want to emphasize waste being a thing that we do to patients and not improving their outcomes. But there is a lot of dollars that is wasted in the order of almost $1 trillion in wasteful spending in a 2019 publication. And that's a quarter of the entire US health system spending. And, potentially a third of that is saved by reducing waste. And when I say waste, what do we really think about within our control as clinicians? A lot of that healthcare costs are not within our control. The administrative complexity and layers that are forced upon us, and that happen on overarching levels, particularly in parallel industries such as insurance, pharmaceuticals. Those are not within our control as individuals nor as departments. But things that are overuse of over-testing, over-diagnosis, over-treatment, a lack of coordination, fragmentation, underusing high-value services, and then misuse as well. So why do we as humans, as doctors, as clinicians, why do we order unnecessary tests? And this is a summary of many different studies that have surveyed trainees as well as practicing physicians about the reasons behind why we order unnecessary tests. And I like to ask my interns this when we start off during our high value curriculum for our interns at the Duke residency in internal medicine. A lot of it is because that's how I learned how to do it, because that's what the preeminent chair does. That's how I learned, because that's just how we do it here at Duke. This is the culture here. The litigiousness is always thrown out as a reason, though studies have shown that it is less of a true reason than what we fear it is. Then come in the factors of lack of understanding of the cost of the test, the operating characteristics, pre-test probability, the negative predictive value, all those stats that we like to forget until we have to recertify our boards. The unfortunate nature of systems, right? Outside hospital is closed. I can't get access to that pathology block. I am unable to retrieve previous results. And then I'm also uncertain. I think that what we don't emphasize enough is our lack of comfort with diagnostic uncertainty. These are all reasons that we order unnecessary tests. And then I prompt my learners to think about, what do we ask before ordering the test? This is an adaptation of an editorial written by Dr. Lane, the Annals of Internal Medicine editor-in-chief at the time, about asking the simple questions for high-value care testing. Will this result change my management? Fundamentally, we should be teaching our trainees, if you're going to ask one question, start there, right? And that's getting into the mindset of how do we help our learners start thinking about what to do with a test or treatment that they are prescribing, ordering, recommending. What are we asking first before we go through that process? I'd like to start with some fun examples, and these are very, very simplistic, and then also examples that I have seen personally in my own practice, as in I am guilty of doing this, unnecessarily repeating an A1C within that 3-month period, or more realistically, an A1C in people who have just received a blood transfusion. It's not going to be a reliable test. I'm not going to know what to do with it. it a it is cold and flu season, as my kids in daycare definitely know. They are coming home with runny noses and coughs. They don't need a Z-Pack. Is it just to reassure me as an anxious parent of kids? I don't need to take them in for every single fever that happens, but we are doing testing that would not impact care just to reassure the patient. Things that we might be deferring to the outpatient setting. I'm a hospitalist. I don't need to do everything while they're here in the hospital with me. We have phenomenal primary care clinicians in our Duke system that I can rely on and communicate with to think about the location of care as well. But thinking about the high cost, not necessarily being low value, right? De-emphasizing the dollar value here. A nice 2x2 table that vaccines, of course, are hopefully a low cost and extremely high value intervention if we can get it to the people who need them. And then things that are high cost and low value, but also high cost and high value, primary prevention, ICD, or screening colonoscopies at the recommended intervals. So this is kind of the framework I think about when I start having that conversation with in particular learners, but also let's have that conversation for us habituated physicians as well, that we are not talking just about costs, about reflecting on our practice, right? There is a need to be thoughtful about the care and not just minimizing care. These two very respected thought leaders in high value care, Dr. Aurora, who is the dean at Chicago now, and then Dr. Moriatis, who is now out in California, leading a lot of work in high value care. But what we don't want is to get into the knee-jerk reaction of minimizing care, period. So now that we have a shared understanding of waste, and we're not talking about just dollars, we're not talking about just reducing things, we're thinking about what is the value overall. What is value, right? So let's back up a quick second. What's a vocabulary lesson here? Costs, charges, reimbursements, prices. The C-suite thinks about all of these things, but let's simplify it a little bit. I like to think about it in a conversation about a restaurant. I'm always hungry, and when I think about costs, what is the cost for the restaurant to prepare the meal? The charge would be the price that they list on the menu. And then the reimbursement is once you use your coupons, you get the value deal. What are you actually paying for the food that you walk away with? So going back to costs, charges, and reimbursements for healthcare, the dollars to deliver the intervention plus downstream costs and harms have to be taken into account, and the overhead that's there. Charges are often a black box that our institution will put out there. And then the reimbursement is something that thankfully our institutions are negotiating for us often as providers. And as a hospitalist, I have the luxury of not having to deal with most of any of that directly, but it is something that we have to think about constantly, because value is fundamentally the quality of the care, right? The patient's outcomes, and then the denominator of costs. The higher the costs, it is going to drive down the value. But if we can increase the quality, that's something that is really in our control as clinicians. Rational care is not rationing, and high value care needs to be cost conscious, but that's not the only thing we think about. So I want to spend the majority of our conversation today thinking about strategies to reduce low value care. I think about it as a roadmap that builds upon different steps. We are constantly working on all layers of this roadmap, and we'll delve into each of these 6 components as we go through, but they do build upon each other, and it does require a lot of forethought and integration into thinking about how do we approach this as an institution, how do we approach this as a system, and then also as individuals. So obviously first is to understand what is good patient care. What are the guidelines that exist? What is low value? What is waste? What improves value? Thinking about the evidence, right? We learned during COVID that we have to create the evidence. We need to put in those, do the research trials, prove that interventions like ivermectin and hydroxychloroquine are not the answer, but dexamethasone and remdesivir do improve outcomes, right? We have to develop the guidelines, develop the treatment answers, and that's what big research institutions like Emory and Duke can be drivers in. And then also relying on our specialty societies to think about guidelines, right? We all are looking towards our ACC AHA guidelines on how do we manage heart failure with reduced ejection fraction based on the most recent landmark trials. We have things we do for no reason, which is one of my favorite series in the journal Hustle Medicine, which is kind of a consensus-based discussion of like, here are things we can easily probably get rid of. The American College of Radiology puts out appropriateness criteria, choosing wisely by the ABIM Foundation, which is now sunsetted, but is still part of the conversation around what do we as a specialty, whether it's internal medicine or any of our subspecialties, say are things that we could probably safely reduce. And then, of course, our prevention and screening and thinking about primary care as well as a specialty society. So we have groups that come up with consensus based on evidence as well as eminence and thinking about what is out there in terms of patient outcomes. And we have that. We have to teach our trainees as well as our teams about the appropriate use of cost of care, right? We have, I have a colleague here who signs every single progress note, PGY 36, or I think it's now 37, because we never stop learning. And that's the fun of being in medicine, is that every patient we get a chance to learn from, but also we have a responsibility to continuously learn about the new evidence, as well as thinking about new guidelines that exist. So students and our trainees, of course, you're actively learning in a formalized process, but we are also, it's incumbent upon ourselves as practicing clinicians to think about the appropriate use and costs of care, and then educating our teams. One thing I wanted to talk about when it comes to education is, why don't you just show me how much things cost, right? I don't know how much things cost. If you were to show me, if you were to teach me that, you know, this medication costs a lot, I would use less of it. I am a smart shopper. Well, there is a plethora of evidence out there that there is a general lack of awareness of cost by clinicians. And also price transparency in and of itself is complicated. I am often up at 3 o'clock in the morning right now with my 3-month-old, and I will go onto my Amazon shopping app. It is Black Friday week and there are deals, and I'm like, oh, 15% off. And I'll click add to cart. And then I'll be like, wait, 15% off of what, right? It's not just like buying on an Amazon cart and then putting it into my shopping cart and saying, okay, it's going to show up at my front door. It's not, I'm not looking at the overall total cost. This is not grocery shopping. This is not stuff that's coming out of my pocket or my credit card statement, right? We are thinking about who is actually impacted by the costs. Where are the reimbursements going? What is the price for this patient? Is it an out-of-pocket cost? Do we show relative dollar signs? How do we know what their insurance company has negotiated in terms of reimbursements here? Do we show price transparency for all the labs, every single thing? Is it for just the high-ticket items? Is it just for the waste? And then all the trials that have existed out there are worried that it's not a durable effect, right? There is habituation over time. If you constantly say that we have, you know, a $3 sign PET CT, I'm going to become habituated to those $3 signs. And then the $1 sign X-ray sounds cheap. Let's get it into the PET CT, which might be a wasteful thing. So there are studies that I will not go into each individual one right now, but there's some great reviews on price transparency alone not being a panacea. So the other big question with price transparency is, who is actually the consumer here? Is it us as people who order it, or is it the patients? And January 2020, you might have lost this amongst all of COVID, but CMS rule required hospitals to publicly post their charge master, which, if you ever looked at a charge master, is the most indecipherable Excel spreadsheets. that is not really informative for patients. It's hard for me to interpret, and I spend most of my academic career thinking about how do I analyze this. So it's not like patients can become consumers, especially in my field of hospital medicine, where patient shows up in the emergency room or is directly admitted from clinic. They're not choosing often where to become hospitalized or when they get sick and deal with those costs, right? So price transparency, before we delve into that is the answer, I'm going to just say, no, that is not the answer. There needs to be so many more layers of efforts and impact here. So then we think about behavior change and still, how do we teach high value care, right? We said we need guidelines. We need to educate our trainees about guidelines, not just about the costs. There are circumstances in which high value care, high value cost conscious care is learned. And first and foremost, it needs a supportive learning environment. And we have to start upstream. Fundamentally, my passion and what I do the most here at Duke on is teaching, particularly medical students who haven't formed bad habits yet, about practicing high value care. We have to think about forming those good habits upstream. So here we have a row of ducks. It's not just a picture of a whole medicine team on rounds. I use these ducks to think about the concept of imprinting, where we learn from our leaders how to do things, right? We follow the leader. We are a bunch of little ducklings when we are in training, and there is evidence about how we, in residency and fellowship, the way we learn to practice is a way we continue to practice for the rest of our career. The habits we form will persist. If we train in a high intensity environment, we are going to continue to train in we're going to continue to practice high intensity care. Oftentimes, academic health systems that are strong research institutions that are quaternary referral centers are high intensity environments. So the bad habits that we teach our trainees currently, institutions like Duke, like Emory, like Penn, where I did my training, we are forming bad habits often. And so teaching our learners to practice cost-conscious care up front is going to be very important. So one of the things I like to say that as an institution, just start celebrating the restraint, right? We all want to diagnose a zebra. We are internists. I see some phenomenal clinicians on the call today who know everything about anything and can tell you exactly what specific enzyme to test for a inborn error of metabolism. But we don't need to do that for every single one of our patients, right? We have to celebrate the restraint in addition to celebrating the awesome morning report diagnosis or the CPC diagnosis. So this is a screenshot of an actual secure chat I had with a trainee. I do air high fives still. COVID is over, but not over. So air high five with my trainees. It's hokey, it's lame. I'm not cool. I get that. I'm kind of past the point where I need my team to think I'm cool now. So I'm just going to own it. We're going to do that really silly air high five. And I'm going to call out the moments of restraint, whether it's private in a secure chat with them, texting them in team rounds format in front of the nurses, whatever I can do to continue to celebrate those small wins. So let's talk about some work that we have here with our Duke Medicine residency on reducing labs. Everyone wants to find the best way to reduce daily labs. It's just a drop in the bucket, but since it's a universal problem, I'll share some of our work that we presented at an SHM conference this past spring on intervention to reduce low-value CBCs. And I want to particularly highlight Dr. Duffy's work here. He was the chief resident at the time he was doing most of this, and it was happening at at the Durham VA. It was a modified Delphi method to come up with a shared consensus on what residents defined as low value and what residents defined as stability in their daily lab. So the residents went through several methods or several rounds of this Delphi process to say, this is what we say when we say labs are stable, right? Society of Hospital Medicine Choosing Wisely guidelines say, do not order routine daily labs in the face of clinical stability, but there isn't anything out there yet. We are working to hopefully find some consensus. So this is unpublished data. Please don't share it too widely yet on what we have defined as consensus. And then we showing them in an audit and feedback intervention on resident defined standards, reduced the CBCs per patient day, did not impact chemistry panels, interestingly, in this study so far. And fascinatingly, it reduced the patient declined labs. As many institutions are suffering, our phlebotomists, we often have shortages. If you had to bring the phlebotomist back again after they decline a lab, that is increased workflow, potentially impacting their retention that they were looking at the VA. And so the number of times a patient had to decline a lab and a phlebotomist had to come back was also reduced, which is a fun way to think about indirect additional benefits. So what we saw in this work was that we started with a shared mental model, gamifying it a little bit, having a dashboard, making it about teams, so it's not just us as individuals, and then celebrating incremental wins. And so when we're going back to this framework for high value care interventions that institutions can lead, we have to do it safely, making it evidence-based, targeting us as clinicians, as individual level, and then also like bleeding into institutional level efforts. So now I'm going to pivot a little bit into institution-led change. What can a department of medicine, what can a health system do to really foster the drive that exists to practice the right care for the right patient at the right time? We all want to do the right thing for our patients, and how can we design systems to make that easier for us? I am fascinated by the work of the Nobel Prize winning economists, Richard Thaler, and behavioral economics, and thinking about how do we drive the right thing to do, right? So the short answer is just make a BPA for that. Show me when I'm in Epic. No, right. No one needs another BPA, even if it could be effective. It's burning us out. I don't want one more thing to dismiss. I don't want one more thing to make my day already slower. I'm already dismissing secure chats right now, even though I'm signed out of the secure chats for this conversation. Stop making my work harder, right? The BPA is not the answer, but there are ways to think about clinical decision support systems to make the right thing to do the easy thing to do. And yes, sometimes the answer is a best practice advisory. There are many different flavors. You can display information in real time, subtly, and we'll talk about some examples. There are early warning systems, some particular sepsis alerts. There are dashboards that you can show, and particularly in the clinic setting for health maintenance reminders. Order sets are forms of clinical decision support systems, right? If you are going through a admission for a acute sickle cell pain crisis, patient coming in with that, having an order set that includes some great evidence-based medications that you might forget. Let's think about that. Let's make it the right thing to do, easy thing to do if it's right there in your face. A way to match patients with research trials that exist. Let's continue to drive and build that evidence. Limiting options, right? We don't need 35 different flavors of ice cream. If you remove an option and you don't hear anybody complain about it, they probably didn't need that option. And then using if this, then that order support algorithms. And then something that I'm sure researchers will investigate. I am excited about potential roles for AI. There have been a few studies looking at AI support in diagnosis. I'm thinking about like Adam Rodman and Zahir Kanji out of Boston have just published some work on, is AI as good as a doctor in diagnosis? And we don't know that answer definitively yet, potentially, but can it help us make decisions better for our patients in high value? So I think it's an exciting new field that we can all keep an eye out on. So let's talk about one example of a BPA that we implemented, but also in multiple different steps. So hospital onset C. difficile infections is something that we pay attention to as a hospital, not only because we don't want our patients to get sick, but also the hospital loses money, right? When we have hospital onset C. diff infections, it looks bad on the numbers and it's bad in terms of reimbursement as well as impacting the patient negatively. Hospitals want to find ways to reduce C. diff infections that are not true infections, but just a positive test. So one of the things that we have done was integrating a health record clinical decision support as well as targeted test restriction. And this was Nora Karlovich, who was a medical student when she led some of this analysis of the work. She is now here as she's back after residency and as a fellow. Gosh, time is flying by. But we did come up with a very fun, catchy person sitting on a toilet best practice advisory, but then iterated that with, in addition to discontinuing the laxatives, our second step was a contextual rule-driven order question that requires clinicians to justify the insufficient documentation of diarrhea, as well as auto-canceling an order after 24 hours if a stool sample wasn't received in the lab, right? We all get the page in the hospital of, hey, this patient had diarrhea. Can you order a C. diff? Sometimes we work with our teams and explore a little bit more what they mean by diarrhea. Sometimes we say, great, I'm cross-covering 75 patients. I will just put in the order of the C. diff sample. Then they don't have diarrhea again in the next 24 hours. It's not C. diff. So auto cancel. And what we showed was that with these multi-step interventions, with best practice advisory, including clinical decision support in real time, as well as changing the system to auto cancel in the background without anyone being interrupted in their workflow, we can safely reduce the number of C. diff testing or the rate of C. diff testing. And so when we think about multi-step interventions, the other thing to do is make the right thing to do, the easy thing to do, nudging people. And that's where behavioral economics and behavioral interventions comes in. This is a phenomenal paper written by Zeke Emanuel and the team at Penn, which has come up with their own nudge unit with Mitesh Patel, Kevin Volpe, David Ash, and many leading researchers. I love being on Zoom sometimes for talks because you can actually show a slide with a lot of words and people can read it versus showing it on a big screen and no one can read it. So I guess there is good things to being on Zoom. You can deal with my very tiny font of table 1 here, where humans, borrowing from the field of psychology and sociology, there are smarter people than me who study why we make the decisions that we make, right? Sometimes too many choices is a bad thing. Relative social ranking, we all are the best, right? We are all excellent. We are all the #1 institution in our region. We are all the top specialty in the entire department. We all want to be the best. And so if you tell me that I'm doing worse than my peers, I'm going to want to fix that, right? It's human nature to want to do as good as or better than. It's at Lake Wobegon effective. We are all better than average. And then also we don't have unlimited willpower. It's a lot of energy to make the right decision all the time. If we go to the outpatient setting, you are more likely to get an antibiotic prescribed to you for URI symptoms if you are seen later in the day in the afternoon, because by then you're extremely hardworking, most likely undervalued primary care clinician has already spent a lot of time convincing their 15 other patients that day that they don't need their antibiotics. So by the time 4:40 rolls around, they might not have willpower anymore. I say that with the utmost respect for our primary care colleagues. They work harder than I can ever work. And I think that they need to be paid so much more in all locations. But that's just my 2 cents. And as a hospitalist, I'm extremely privileged to work with patients who are there when I am seeing them. But this table 2 in this paper also looks at behavioral economics incentives for physicians. So one thing in particular I liked that has been studied over and over again is providing social ranking without financial incentive. So that's the audit and feedback. You'll hear that term a lot when we think about high value care and institutional changes, in particular quality improvement processes that say, let's show you how you're doing so you can make a change. Give me the information so I can make a better decision. I like my autonomy as a clinician. Give me information and I will change. But if it's a black box without information, it's really hard to change my own practice, right? So we are responsive to comparison to peers, and physicians in particular are responsive to data and numbers. So making my data available, whether you show it to me in comparison or blinded, that is those powerful. This is a paper that was published in 2019 thinking about like different ways to provide audit and feedback, because it can be informational. So just saying like, hey, did you know that there is a new first-line medication for C. diff infection? Do you want to try vancomycin instead of metronidazole? Did you know? And then audit and evaluative feedback, right? Are you motivated to change? If the answer is no, then maybe saying, hey, your colleagues are all ordering a flu vaccine before this patient is being discharged. Would you like to order this flu vaccine? And then also thinking about, is a provider aware of a substitute? That's the audit and suggestive feedback. So I might know that something is low value. I may be motivated to change, but I might not know what to do in exchange, right? So an example would be, if I wanted to prescribe a biologic medication and I know it's super, super expensive and I don't know what the biosimilar is, if a system was able to say, hey, look, here is this biosimilar version of this very expensive biologic drug, would you like to order this instead? Or as an institution, how about we carry only this biosimilar for 99% of our patients? That's when we start getting into the real cost savings, right? No one's going to save the finance of the healthcare system by reducing a CBC daily. We are going to slowly, incrementally make change and change the culture by talking about it. But really, we're getting into these system level changes to make an impact on the overall costs of care, as well as driving the overall value. And the provider practice variation is another way we can use audit and feedback to say, why are you performing so differently from your peers, right? You are seeing in general the same type of patients, the same overall acuity of patients. It's not like I, as a hospitalist, get to pick how sick my patients are. The 15 patients I'm seeing are most likely going to be very similar in acuity to the patients that my partner is seeing next door. But regional variations in spending then shift practice patterns that don't correlate with quality. And one particularly egregious example I like sharing is that a region that performs more CT scans because perhaps their trainees learned in a more intense environment, they find more incidental renal lesions, of course, and that leads to more nephrectomies without a change in impact of care. So you can live in one part of the country and have a higher likelihood of having a nephrectomy simply by the fact of where you live, which is, when you put it like that, it's kind of mind-boggling, right? So then let's look at a couple of examples of how audit and feedback could work to really impact the care. So this is a peer example comparison that our primary care clinics used here at Duke, published in 2020 in JGIM. And this was, the panel A is rate of imaging orders per 1,000 patient encounters. You can see there is a wide variation. You have outliers all the way up here on the right-hand side, and then you've got some negative outliers as well. And then what the clinic medical director did was simply show at the bottom of their annual score or monthly scorecard, here is how many imaging orders you've done compared to your peers this month. This is how many you did. This is how many your peers did. On average in the previous year. So you can see what most people reduced downward the number of orders they put in, and that drove a trend towards the mean, so reducing some variation. And this is a beautiful statistical control chart that showed overall, even within 2 standard deviation ranges, they decreased the rate simply by implementing that one intervention, by showing in comparison to their peer group, how they were performing. Then there's the behavioral strategy of gamification, right? We are all in this together. We're working together as a team. I want to win. Because most of us are quite type A physicians, right? Internists, we're the best doctors out there. We are better than other specialties. We are going to provide better care. And so then reducing variability by displaying information in a scorecard and then showing ways that people can win. I like this example from the surgical literature because it showed the medical surgical supply costs directly for their procedure, and they posted it in the hallway of the OR and said, hey, look, Surgeon A, your colleague is doing this cheaper than your colleague Surgeon B is doing it cheaper than you and doing it faster. And then also, hey, your division can get a financial incentive. It's like a big pizza party on steroids, right? If you share that win, if you meet a goal, you're going to show people that they're all invested. And so some of the takeaways from that kind of work is that we all have a shared goal and shared accountability in that goal. Thinking about in-groups and out-groups is often successful if you are doing it in a positive fighting way, right? In that surgical example, they pitted surgical divisions against each other and who could save more money. And I think that's a positive way to frame it and not say that one is better than the other, but one is achieving more value than the other. Visualizing the progress, the fundraising thermometers, that could be a great way to visualize it works in real life, so it can work in the healthcare and academia setting as well. And then having a stake in the outcome, that shared savings, right? The division got money back if the division was saving some reduction in the costs over time. So building upon the behavior change and systems design, designing healthcare systems and operations to make it easier to practice high-value care. This is a very wordy slide on purpose because it says there's a lot of different ways to show the information, help us make clinical decisions or clinical decision support systems, reduce waste. These are all examples of things that we have done here at our healthcare system. And we don't have data on all of them, but they are small changes that overall is adding to this culture of high value care that we are attempting to promote and propagate. Then we have to track it, right? No one wants to put money towards efforts unless you prove that it's working. Qualitative data is not the only answer, but metrics in themselves don't tell the whole story nor the perfect story. Wanted to share a few more examples of how we can put some real-time info into the EHR, and then how some of these small metrics can make a big difference. So a study in 2019 published in JAMA Internal Medicine simply showed that the telemetry order on the inpatient side was expired. Okay, you want to continue it? Do you not want to continue it? Guess what? People didn't realize their patients were on telemetry. That has been proven over and over again that clinicians don't know if their patients have Foley's in, if they've got telemetry in. It's reduced telemetry hours significantly, which we think about then delirium and tethering and all the negative downstream impacts that happen to our patients. When we change a test processing, this is a remarkable drop in urine cultures that were sent before elective joint arthroplasties. Because guess what? They did a forced function. The routine preoperative cultures were not processed by the labs unless the ordering person called the microlab and said, I really do want this. When you make it harder to do, suddenly you're getting less low value care. It's like when I tell my trainees, hey, if you really need those labs, you should be willing to go and draw it yourself, not just say, oh, well, I don't need it today if the phlebotomist can't get it, right? Then care pathway redesigns that happen on a system level. I'll shout out the great work done by your team at Emory, published in JHM just a couple weeks ago. And you can see the awesome group of authors there on redesigning some care pathways. They helped create this infographic, and I'll zoom in on the bang for the buck that they got. Shorter length of stay. if your hospitals are anything like our hospitals, that is like the that is cake and the cherry on top for administrators. Shorter length of stay. Wow. All the numbers that come with that. They develop a short stay unit at and you guys know more about this than I do, so I feel bad trying to tell you about your own work, but I want to highlight and shout out the great work that your team did in reducing waste and improving value by creating a new pathway. One thing that we have done here is a new redesign of implementing separate pathways of care for patients with opioid use disorder, our COMET team, or caring for patients with opioid misuse using evidence-based treatment. So what we have looked at is, okay, we have a patient with OUD who would otherwise stay in the hospital for a prolonged 6-week course of IV antibiotics. We developed a standardized process for OPAT evaluation, for outpatient antibiotic therapy evaluation, that did thinks about PICC line safety, works with infectious disease, works with our home health care nursing agencies, and then decreasing our length of stay with partnerships with our skilled nursing facilities to take them with a PICC line, or having the home patient even go home with a PICC line with outpatient antibiotic therapy. And then thinking about enrolling them in the DOTS trial, which looks at dalbavancin to shave off a couple weeks of their antibiotic therapy. So this work, summarizing that, standardizing workflows, thinking about pathways and partnerships, shared decision-making, shared responsibility, as well as an equity lens for vulnerable populations that might otherwise not have people being creative enough to think about how can we get you out of the hospital safely, and reducing the stigma that comes with patients who inject drugs. So with the COMET length of stay work, it was going back to this framework where safe, evidence-based, provider-level, institutional effort, and as well as system and multi-level studies. A few more examples, blood cultures, right? Blood culture bottle shortage. I'm sure you guys suffered from that too when the BD Bactec blood culture shortage was happening. We rapidly had to think about what are the conventional ways that we order blood cultures, what are the contingency when we have a shortage, and what's crisis mode when we have like almost nothing. Centralization and communication. These are things that happen during a crisis, but it does require multi-system work to think about regulatory advocacy as well. What does it really mean when a blood culture bottle is expired? And then now let's summarize with keys to implementation. I am not a organizational psychologist, and I am not a health system services researcher, but the financial incentives for high value care need to be aligned to make the right thing to do the easy thing to do. Right now, there is too much weighing us down that makes the battle quite uphill. It will take an act of Congress to really make the system better. And there is some traction on reducing prior authorization burden. And one example that has been supported in some ways by the health insurers, as well as the AMA and other healthcare institution or healthcare organizations, is a process called gold carding, right? If you do something really, really well, let's say 90% of the time you are getting your prior auth approved, then great, you're doing such a great job, we're going to stop auditing that. We're going to stop making you do prior authorization. There are a few bills in Congress that are looking at making gold carding more frequent, and keep an eye on the legislation that is going to be coming out. Perhaps with a new administration in Congress, this might become less or more of a conversation, remains to be seen. But those are multi-institution level ways to think about gold carding. We have to align incentive with value, right? Whether it's gain sharing, the wins come back into our own pockets, or we get to decide how the department savings get reinvested in different pathways, in making us part of the process with whatever cost savings that happen. Creating that culture of high value, cost conscious care is going to require human investment psychologically as well as on an effort basis. But let's summarize by thinking about not about costs, but really about stewardship, right? It's antibiotic stewardship. We all do because it's the right thing to do. Stewardship of healthcare resources is another thing that we should be doing just as easily or innately as antibiotic stewardship, because it's not just about costs. It is fundamentally about our patients. If you leave this conversation today with nothing else learned, that we should do the right thing for our patients because it's not just about money. The cascades of care that happen after low value cause more testing, more harm, more downstream impacts. When we think about downstream, it's not just costs, but it's the time that patient took to take off of work, to take the bus, to get to their cardiology visit after their preoperative EKG. Then their worry that happens. Oh, they had to also pay for childcare that day, right? All of this, the downstream impacts and negative consequences of overuse for our patients. And I love this conceptual map that the Kornstein team put out in JAMA in 2018 on really thinking about short-term as well as long-stream consequences of overuse. When we think about change management, you can read a lot of books about it. John Cotter is the one that is often cited on the 8-step model to change. There are lots of barriers to change. It is easy to say, well, this is a really hard thing to do. And it's hard to engage the frontline clinicians, right? I am 100% clinical FTE. If you ask me to do something that makes it difficult for me to round on my patients, that is going to be really hard for me to engage in. We have to feel like this is something we want to do for our patients, not just something our leaders are making us do for the health system's bottom line. So it does start with teams, as well as the support from the data analytics. It's teams that are coming up with communities and councils that are coming together to say, this is what we should do for our patients because it's the right thing to do. Reducing the waste requires a multi-level interventions with sustained support, and the institutional change must be data-driven and provider-supported on all aspects. So I said this over and over again during this conversation that making the right thing to do needs to be the easy thing to do, but culture change is really, really, really hard. It will require role modeling, teaching our trainees, teaching ourselves, teaching our faculty, aligning our missions, as well as all the other bundles that come in here. So going back to how we built this on guidelines and education and behavior change, system design, aligning incentives to ultimately lead to culture change. It all seems easy when I put it together like that, but really it is some extremely hard work that can start with us as individuals asking a few basic questions, and then fundamentally realizing that although we are part of the problem of waste in healthcare, we are part of the solution. And cost consciousness is about helping our patients and doing the right thing to make sure that they have better outcomes. So thank you so much. I would love to chat with you more about what's worked, and I will pass it off to Dr. Del Rio.
Thank you, Suchita. This was truly fantastic. I want to be a little bit of a cynic, maybe say that, but, I've been hearing about, the transition from volume to value since the early 2000s. It's 25 years that I've been hearing, we're going to do it. It's going to happen. It's going to happen. It's going to happen. And yet it never happens because the incentives in the system continue to be to make money, spend more money. The more you do procedures, you talk to your CEO, he'll tell you, or she'll tell you that, do more procedures because that's how the health system makes money. Nobody says by doing quality, by doing value, we're going to make more money. So I really want to know what is it going to take to really have this happen, and why have insurance companies and payers not embrace this?
Dr. Del Rio, you've definitely hit the nail on the head there, right? We are all going to be milking that fee-for-service cow until that cow is dies 1,000 deaths. Until fee-for-service truly goes away, it's going to be impossible to change the ingrained systems because we are so reliant on that. However, what does work in the meantime is thinking about what are the changes that are being forced upon us already. We aren't going to change overnight the reimbursement processes from the federal government, but when a health insurer is saying, guess what, we're not going to pay you for this readmission for a patient who came in with a prosthetic joint infection after an elective replacement, because this is a complication you should have avoided, then we suddenly start to make moves. So I think that the real impetus for change is happening more and more actively in the insurance and private payer markets, thinking about how do we force our institutions to save the dollars on the private side. So that's a really cynical way to look at it, absolutely, that it's truly about the bottom line. And at the same time, our patients and the affordability question, the financial toxicity is becoming more and more realistic. We don't yet know the fate of the Affordable Care Act and Medicaid expansion and what will happen over the next 4 years. However, if healthcare is unaffordable and more patients are individually experiencing those personal bankruptcies or financial debt because of it, those are going to be the reasons that we really think about as individual clinicians, how do we make the system better for them? So I think our patient suffering is going to drive a larger level change, and then the financial stick instead of the carrot from the private payers together. In the meantime, we need to be ready when the hammer hits. We need to be ready to practice in a culture of change. And so getting into that mode of, I know what the right thing to do is because this is how I was trained and this is how I'm ready to do it. I think we'll be ready when the fee-for-service cliff finally hits. But you're right, your guess is as good as mine when that's happening.
Thank you, Dr. Sata. So Carlos had a really sort of long-ranging question about how are we going to get there. I have a really practical question as we sort of round out this hour. You mentioned your teaching of learners and engaging them in high-value care. And I love what you said about recognizing moments of restraint. So I wonder if a great way for us to leave this talk with tangible action items is for you to share with us some examples of what those moments of restraint might look like, since sometimes if we haven't identified them before, we may not even realize that we're doing it, or maybe things that we should be doing that we're not aware of. So what are some examples of moments of restraint that you often identify on your teaching teams that we can carry forward onto the work that we do this afternoon?
Wow, that's an excellent question, Dr. Law. I have it easy because I am a hospitalist and it's happening all the time, right? So one example that was forced upon us because of the IV fluid shortage is the potassium versus pill versus IV, right? We are often ordering IV potassium supplementation because it's super easy. It comes first in the board. But then when we are forced to not have it, guess what? Everyone's getting those big pills. And our nurses were happier because now they're saving their time hooking up the tubing. Patients are happier. It's not burning their veins. It's those downstream impacts there too. So celebrating like, hey, thank you now. Yeah, our IV fluid shortage isn't as bad, but thank you for choosing to order that pill potassium and you save the patient 500 cc's of IV fluid with their 40 milliequivalents of potassium. So that's one way, like even just simple things like that, or asking the learner, hey, talk me through your reasoning of why you chose to get an ultrasound instead of a CT. That's fantastic. You're right. You don't need a CT to diagnose a portal vein thrombus. You could start with an ultrasound, and then you can confirm with cross-sectional imaging. So things that are forcing the learner to talk through and acknowledge that they consciously made a decision that was a high value decision, and that talking out loud their thought process will then reinforce that learning point. And then of course, signposting. Thanks for teaching us why you got the ultrasound. I think the important teaching point here is an ultrasound is a great first test for this particular purpose. That's some great teaching that you just did for our team. Repeating that you've learned, that you've taught, and that it's high value will continue to solidify that.
Fantastic. Implementation of high value care. Thank you so much for joining us. We're at 1:05, so I think we're going to adjourn here. Happy Thanksgiving to everyone. Again, as a reminder, next Tuesday, there will be no Department of Medicine Grand Rounds, and then we will resume on December 10th. Thank you all, and thank you, Dr. Sata, for joining us.
Thank you. Have a good Thanksgiving.